And it's going. Hello guys, this is Jonathan Munoz, and today we're going to talk about hospice and when is my patient eligible for hospice. And hopefully this serves you for your observership rotation, your first year as an intern, or even the interview day that is coming for this season. So hospice is a program that is that takes a multidisciplinary approach with doctors, nurses, social workers, chaplains, and what they do is they help the patient and the family transition into this new process, which is the end of life, and to ensure that this process is very comfortable for the patient, that the patient is not in pain, this patient is not in distress, that the family is reassured, that the family feels supported, and or even if they change their mind, decide to change their mind, they know that they can change their mind and go back to the hospital. So in hospice, what do we do in hospice? For example, I was a hospice doctor at the beginning of my career post-graduation for a couple of years. And what I do is, once I've been called for a patient that needs to be on hospice, I go assess the patient, talk to the family about the diagnosis that is causing this patient to die, and explain the medications that we have available in hospice. For example, we have a lot of sublingual medications like morphine. You have to know what are the transformation for sublingual morphine in comparison to IV morphine. So it can kind of give you an idea of, okay, how many milligrams of sublingual you need to get the effect of IV morphine. But usually 5 milligrams and 10 milligrams what we do for sublingual morphine. There also is Ativan sublingual, and with 1 or 2 drops you're good enough to have a patient calm and relaxed, not agitated anymore. There is a lot of medications for nausea, for vomiting, for excessive drooling, and you will easily learn about that. I'm going to post some pictures I have on a booklet on all these hospice things. But the idea is that you basically have a family that has chosen to be at home for what is rest of the loved one, and he has decided to stay at home, not looking for more hospitalizations, and accepting that this disease is going to kill them, and they want to die at home surrounded by their families. They don't want to live or die abandoned at a hospital room or at a nursing home room without any family around. So you have to respect these patients' wishes, and if the diagnosis is appropriate and you are doing all your due diligences to ensure that this process is transparent, then you place a patient in hospice. Now there are different the patients. So who qualifies for hospice? Let's say you're on an internal medicine rotation and you're dealing with a patient that is CHF, systolic CHF, acute respiratory failure, and he is 85% despite being on 6 liters and very uncomfortable, very short of breath. He's very cachectic, and so you say to your attendants, so we're doing the recess now, we're going to put him on a Lasix pump, and the attending asks you, do you think this patient qualifies for hospice? And the answer is yes. Now, it's not just because he looks terrible and he is in a lot of oxygen, but it is because he meets hospice diagnostic criteria. For example, he is on stage 4, NIHA stage 4 for heart failure. He is on multiple readmissions to the hospital. His functional capacity, which is measured by the Karnofsky functional capacity scale or by the functional palliative care functional capacity scales, demonstrate that this patient has lost function. And so you document that, you say, yes, based on his presenting NIHA classification, based on the loss of functional capacity, based on the raising need for oxygen, I believe that this patient will be a good candidate for hospice. So the attendant said, okay, talk to your case manager, contact the hospice agency, and connect them with the family. So first, before doing that, you have to ask the family. You have to ask them, hey, it has come to a point that Mr. Munoz is very delicate and he is not improving. We can continue our current treatment, but I want to tell you, maybe you have felt this way, that he is missing his home. He would like to be at home. He doesn't like to be here. He sometimes refuses treatment and asks for his family. I have to also tell you that one of the alternatives of treatment that we have is for patients that are very debilitated and not doing well, is to look into the possibility of hospice. And what hospice is, it's a service where we ensure that a patient that has a terminal illness will remain comfortable with all their symptoms treated, but without the intention to cure the disease. And this may happen at home or at a nursing home if you want, but usually patients want to be at home on their last days. And if he has decided that he doesn't want to be intubated, he doesn't want to be resuscitated, he just wants to be comfortable without pain, then hospice will be a good option for him. And so would you agree? And if they agree, you just call the case manager. The case manager gets a hospice company, they sign papers, the patient is sent home on hospice. Now, who qualifies for this? So let me give you the names of these scales. So for a patient that you think that is doing poorly and is not improving or has a very serious disease, you have to calculate the palliative performance scale that tells you what is his capacity. Usually we're talking about considering hospice if the capacity is less than 50%, and that includes inability to ambulate, mainly in bed, totally bed bound, multiple needs for assistance, drowsy, confused, comatose. Then you also have to calculate, well, you don't have to, but it is good or supports your documentation in your note, and your attendants will be very impressed when they read a note of you saying the Mitchell Mortality Risk Index gives us 5 points, and with these 5 points the patient has a risk of less than 6 months to live. So you calculate that Mitchell Mortality Risk Index, and you can know how likely is this patient to die in the next 6 months, which supports the idea of this patient belonging to a service such as hospice. And every disease that you may find has a specific criteria. For example, for cancer, there has to be evidence of metastasis, or the patient has declined to get more therapy. For Alzheimer's dementia, there has to be documentation of the patient being on stage 7 of the functional assessment staging scale for dementia, which is basically a patient that is non-verbal, comatose, in need for nutritional support, and what else? Then for heart failure, is a patient that has at least documentation of being on New York Association scale of 4, and the last thing I want to say is not every patient qualifies. Not in the past, any patient that will present failure to thrive, just because failure to thrive, doesn't qualify for hospice. For hospice, the diagnosis that qualifies a patient for hospice is called the primary diagnosis. So just be mindful of of when to decide to say this patient will be better served at hospice. Once you get a hang of the idea of who qualifies for hospice, then it's easy to say this one, this one, this one, and they will benefit. It's a if the family understands, or the family is on the same page with the patient, they understand the concept, and the patient talks to them if he's good enough to make them know what he wants to do. They all accept. It's a very happy situation where everyone feels relief of not being in the hospital anymore. So it's difficult because you have to explain what is hospice first, because not everyone knows. You have to explain that this is a service, and you have to explain that the patients were looking to not to have this patient readmitted to the hospital unless they want to terminate their hospice contract. And why is this important? Why is this important? Not only because it reduces the use of ICU beds, because you don't have to intubate or resuscitate a patient, so it's less expensive for the system. But most importantly, is because if you have taken time to identify your patient's wishes and what is important for them, you may have come with the thinking this patient should be at home. So most importantly, you are respecting your patient's wishes, and you are making this patient and this family happy to be together in their last days. If your curative treatment attempt is not going to change anything, then why to subject a patient to that suffering when he could be at home? So think about that. And now, how can you use this information in your interview process or anywhere? It's because, for example, when I applied, I remember I said one of my big interests was to learn more about hospice care, palliative care, because in my culture in Peru, there are many. I know of many families that would like for their loved ones to die at home, but they cannot bear with the idea of not doing anything or stopping curative attempts for their parents and just keeping them at home. But they don't want them intubated. They know they are super old and they want to be at home, but they want to continue treating because they don't have a system like this. They don't have a system like hospice that reassures the patient, keeps them comfortable, or their religious ways also get in the picture. So I remember when I was interviewing, I said that one of my interests is to learn more about palliative care and hospice care, and to be able to reach the Hispanic populations and to help them navigate this new option of treatment, which is hospice. And I even say that I thought it requires a specific personality type. It requires you to gain trust, to communicate at this basic level on what is important, to make a family understand what is important for them. Choose your words wisely when you discuss end of life. And I remember the program director that ultimately hired me was very impressed with my willingness to learn more about hospice and palliative care, because it's not a field of primary care that many people would like to dive into, because it takes time. These conversations take time. These conversations can be very emotionally draining. So read more about hospice. I just gave you a little bit of an idea for you to read more and get to this interview very well prepared. So hopefully this adds to your knowledge for the interviews. Believe me, you have to go with something that is unique. There's going to be thousands of applicants. I coach applicants every year, and if they weren't coached, they will go to the interview just saying, "Hi, my name is Jonathan Munoz. and I'm here because I love internal medicine. But now you have this new information, and you can say, hi, my name is Jonathan Munoz, and I choose to go into family medicine because not only I can treat a vast variety of diseases and ages, but I can also deep work into exploring palliative care or reaching families and learning more about one of my biggest passions, which is hospice care. I think it sounds great to me. I discussed this with a lot of students, American students that are also looking into internal medicine or palliative care or family medicine. And you have to have an angle. And if that angle is true to your personality, then you're great. If this angle is a lie, you will be caught and it will be noticeable. So look at all my videos. Maybe you will find your angle, and maybe that will help you with this interview season. Good luck to you guys. I will keep posting, mainly on YouTube, and for the Facebook group, just a picture of things that I want to share with you. But thank you for joining. I'm trying to start this once a week YouTube videos that where you can ask questions live. Hopefully you can join me, ask some questions, and we'll see how this goes. And thank you.